Welcome, everyone, and thanks for joining our discussion about small tests of change. I'm going to be your host this afternoon. I'm Ruth Gubernick, and I'm a quality improvement consultant, and I've been the quality improvement coach for the AAP's Anxiety and Depression ECHO initiative. You know that in recent years, a rise in patient anxiety and or depression being seen in primary care practices has been reported. And that's one of the reasons why having this discussion today about change work matters so much and more now than ever. I am so excited that I have two guests with me today who were both participants in the quality improvement track of this initiative. Welcome, Dr. Deborah Braun-Corville and Dr. Aimee Johnson. So nice to see both of you today. I've missed our discussions on a monthly basis. So if you could each just say a little bit about yourselves as an introduction. Deborah, I'll start with you.
Sure. My name is Deborah Braun-Corville. I am an adolescent medicine specialist practicing in Nashville, Tennessee. And I've been in my current institution for almost 11 years now. And when I initially started there, I was trying to find sort of a niche in the professional development and in the institution and within my division. And one of the areas that was of most interest to me was looking at patient safety and quality. And I participated in a year-long course within my institution regarding quality improvement and learning how to do improving patient care delivery in a variety of different settings and projects. And that sort of has spawned my interest. And that was almost like 6 years ago now. And so as things have evolved over time professionally, I've now started to develop relationships outside of my institution at the American Academy of Pediatrics, and was able to participate in the quality improvement track of this AAP ECHO project that Ruth just mentioned, and previously as a participant and now as a faculty member. And so I'm excited to be here today to discuss some of the things that I learned from my most recent projects, as well as how this can be really helpful for primary care pediatricians and primary care providers to improve care delivery for our patients, particularly adolescents and young adults, or even younger children who might be struggling with anxiety and depression.
Thanks so much. Really appreciate hearing all that. Great. And Aimee?
Hi, my name is Aimee Johnson, and I'm very excited and happy to be here today to discuss this very important topic with all of you. The current institution I'm at, I've only actually been there about 9 months. So I sort of started this project like very close to when I was a brand new employee at the institution. However, I've been in general pediatric practice for about 13 years now. And I've worked in different settings, in an urban setting where I took care of sort of urban poor and underprivileged patients, some refugee patients. And then now I'm in more of like a rural setting. So I sort of have a diverse experience with different types of patient populations. And amongst all of those settings, the one central feature that we often see a lot is that the children are experiencing difficulties with their mental health. So that's why this was a very important topic to kind of look into further. I've never completed a quality improvement project before, so I had no knowledge or experience or understanding of how to do this. I just sort of jumped right in because over the last several years since the COVID-19 pandemic, it's become a huge amount of our patient population that we see, or I guess I'm trying to think of how to say it. It's an additional topic that we as general pediatricians are taking care of more frequently in the last, say, 5 years than we did previously to that. That was more of something, mental health was something more that was a referral type diagnoses rather than something that was taken care of in such depths as it is now, I feel like at the general practice level. So that's kind of what led me to be interested into this quality improvement project.
Great. Thank you. Thank you for sharing that. I'm really so lucky to have both of you. Your expertise in the patient populations that you serve and have served, and your experiences are just going to be really valuable today as part of our discussion. Just to share a little background about the difference between quality improvement and research, there really are some unique differences. When I do quality improvement, it's about being able to bring new knowledge to the daily practice, as opposed to just identifying some new knowledge. And a big part of it is doing sequential observable tests of change. Instead of with research, you're doing blind tests. And the other important thing to remember is that when those of you who are researchers, that you're collecting as much data as you possibly can, just in case you need it, as opposed to quality improvement, where I want to just collect enough real-time data to be able to learn from it and then be able to use that data to create another cycle of change, so that instead of having long periods that it's going to take to obtain my results, if I'm a researcher, quality improvement, I just want to have small tests of significant changes quickly so that I can accelerate the rate of improvement. So when I'm talking about tests of change, just to say that what I mean by that is just putting a change in effect on a real temporary basis. It's on a very small scale. It may be just the next patient that you see, and you will learn from that, and you see what the impact is. It may work, it may not work, but it's really about it's temporary, it's small, and you can learn a lot from it. When I use a quality improvement format or framework, one of the questions that I want to answer is to be able to know whether or not those changes that are being made are going to result in an improvement. So testing change, when you hear about what Deborah and Aimee have done, it really has two components. It can have ideas, it needs ideas or best practices or things that they've learned about from other participants in a collaborative, that are ready to use or ready to just adapt to your unique environment. And the way that's done, and you'll hear them talk about this, is to use like the Plan, Do, Study, Act, the PDSA test method, where a test of change is planned, and then the team does it, and then they study it, and then they determine whether it worked, what didn't work, whether they want to change it or they want to move forward. So just to kind of tell you why it's so important to do testing, again, it's not a permanent change. You're not going to have any support for that change beyond the period of testing. You can learn a lot from it, including the fact that it didn't work, which is really important to learn. And if you only do it with one patient or with a small group of patients the first time, the second time, that fewer people are going to be affected by that. So you've lowered the risk of blowing what you're doing out of the water. And it's going to provide you with enough data to be able to see whether or not what you're doing is actually a better way. And it's something that you want to implement on a broad basis and then sustain because it's working so well, share with everybody. So based on that, I love the fact that quality improvement is a team sport. So that said, I would love to hear now from each of my colleagues here about if you could share who's on your QI team in your practice. What are the roles and the responsibilities of those people, and how do you meet? How do you collaborate to be able to create a test of change? Deborah, I'll start with you.
Sure. I have a practice that is comprised of nurses, medical assistants. We actually have a dietitian, a social worker, but we really wanted to start small. And the project and test of change that we were doing was really looking at, hey, we know that the increased rates of anxiety and depression are happening in our pediatric population. And we might want to refer them for, more intensive services through mental health counseling or mental health treatment options. But what can I do in the office? What can I look at as a primary care provider and help support my patients as I'm trying to figure out what the next best steps are for them? And one of the things that we were interested in looking at is that we know that kids who have strengths, kids that have resilience factors, kids that have positive things going on in their lives, they're probably less susceptible and maybe have more positive outcomes for their mental health than kids that maybe don't have all those things. So one of the key things that I was looking at like, how can I identify and document what strengths my patient has that can bring to them to help mitigate and improve their mental health outcomes. And we really had no reliable way of looking at that in our patient population as it stood when we were previously doing anything. And so, but recognizing it's an important factor, like I wanted to get gather some information and test, like, hey, if I document these things, if I start looking at these things, is this going to improve my outcome to be able to like help share with my patient? Hey, you tell me that these are your strengths. These are the good things. Like, these are the things that I want you to highlight and be supportive about yourself. So I devised a team that comprised of my nursing staff and a couple of medical assistants who would be helping with me with this project. And they were the basis and the primary background for the team members that were involved, because they're the ones that are often, getting information, meeting the patients initially, meeting the families initially. And I felt like they would be really good team members and supportive people to help me sort of devise this project. And so I really relied on them to help look at these questions. What kind of strengths, how are we going to go about this? And we met on a fairly regular basis at first, probably every other week, as we sort of deciding what tests we were going to do, what interventions we were going to do, how we're going to implement this, and how are we going to get the information that we were looking for. So it involves some education at first, but as a test of change, education is really not always the best thing to do. You really want to sort of put things in place that are going to be helpful for patients and families that they can do in the office, or as the providers can do in the office. So I really started with like creating a team of invested people who were interested in supporting adolescents and pediatric patients who were struggling with mental health issues. And that came down to sort of my primary ancillary nursing and clinical staff. And then as the project evolved, I involved other pediatric providers in my office into that project as well.
Great. I love the way you really had a multidisciplinary team, and the fact that you met every other week at least, to kind of devise this is really terrific. Aimee, how about you? Who's on your team and what does it look like?
So my team was smaller because the type of practice I'm at now it's just comprised of me, the physician, and a physician assistant. So there's just the two of us who see all of our patients out in this more like rural clinic. So our team was pretty much me and her, and then we have a nurse, and then our medical assistant who helped with like the rooming and things like that. So it was just a very small team. So our meetings tended to be more casual. Like after you roomed the patient, the parent might have given us feedback directly and they would have come back and told us, or we might have went 2 weeks without really discussing feedback or, things like that. So it was a little bit more casual, but I tried to use the organization of the quality improvement project. Like if we had a meeting once a month about the QI with the AAP group, that would be my indication. Like, okay, now we need to sit down as an office group and talk about it. So that was like my reminder that like, okay, we haven't talked for a while. We need to. So I kind of used that structure as like the point where I would regroup. because everyone knows, like, especially this project was done during the winter months, which is like so busy in a general pediatric practice with like illnesses and everything, that sometimes days just get over before you have a time to, to get to that meeting you were expecting to have. So I kind of used the maybe twice a month we met, because there was always either a QI meeting or the meeting about the educational sessions. And that was about my unstructured meetings that I would have with the team. And then my goal is, after kind of doing this at our very small practice level, the organization I work with has multiple practices within the pediatric department. So then my goal would be to like give this information to those practices as well, so that it could expand farther. So that's just the process I'm at now, is just sort of putting that all together to present that to like the leadership at our office.
Thanks for emphasizing. You show that quality improvement is adaptable to whatever environment you're in, and you've each done a good job identifying what that looks like and what would work for you. Also, Aimee, you're mentioning that you engaged families for feedback, as part of the work that you did. So yeah, they're part of the team too, always. So I appreciated that. Deborah, I was wondering, you mentioned that you focused on incorporating strengths as part of your, as a opportunity for improvement, as part of your participation in this initiative. Could you walk us through a little bit more about how you tested change, what that looked like, in terms of, how you determined that, what kind of data you collected, how long it went on before you kind of looked at how well you were doing or what you learned?
So we first looked at like, what are our performance gaps? So we created a flow sheet that provided information about background and like a planning worksheet, and came up with some ideas like, what are we missing here? What are we trying to test? What are we, what's the important part? So we really kind of looked at the fact that we didn't have a uniform strengths-based screening that we were doing in our practice at all. We routinely, as an adolescent medicine provider, I do a heads history. So I'm really looking for risk behaviors that adolescents have, and didn't really have any uniform way of looking at their positive things. So I was looking at, all of I'm wondering and worrying about all the bad things that you're doing, but what are the good things that you're doing? And so we didn't have any uniform way of like assessing for emotional well-being and adolescent risk behaviors. So what we tried to do is, from my team, we tried to identify some questions that might help elicit patient and family strengths. What are the great things about this kid? What are the positive things that they have going on in their lives? Who do they count on? And based on the American Academy of Pediatrics Bright Futures, as well as what's called a shade screening, which is flipping the heads history, instead of risk factors, looking at strengths and positive things for kids. We devised about 6 or 7 different questions to help, identify some of these positive things for kids. And those came from my medical assistant and my nursing staff. I asked them, what do you guys think? If you are hands on the ground asking my patients on a regular basis, getting rapport with them, developing a relationship as you're triaging them, which of these questions do you think that would be helpful? So we tested, actually, we looked at like doing all of these questions at first. And so, and we created a paper survey and decided that we're going to distribute it to all of our patients who's coming for an annual well visit, because we're going to do depression and anxiety screening as recommended by American Pediatrics for at least annually. And then how are we going to sort of document, okay, I assess for anxiety and depression, but I'm also going to assess for the good positive things that these kids have going on. So we devised these questions and then put it on a paper format, and my nursing staff started out really small, like 1 day a week on the Monday afternoon, where I see all, a majority of my physical patients. They were going to distribute it to all the patients that came in. And that's not a lot of numbers. Like when, I have a half day clinical session, maybe that's a total of 6 or 7 physicals in an afternoon. So we started really small and made sure that the wording was right and distributed to all of our patients, and then collected the information and asked, from those questions. And over time, so we did it 1 day a week, and then the next, we did it a couple days later and tried it again. And then, eventually, got, probably maybe 20 kids to get the information back. And then had my nurses look at it and say, okay, this question didn't work because they didn't understand the question. So we had to reword it. Or it was duplicative. It was like asking the same question over again. And so over time, and then the next thing that we did was we actually solicited feedback from my patients to ask them, like, hey, which of these questions do you think were helpful? Is there something else that we should be asking instead of these 6 or 7 questions? And then the next test was to look at, like, okay, now we have this information. What are we going to do with it? How are we going to document it? Because it's on a paper, then somebody's got to upload it to the chart. So the next step was thinking about, okay, can we put this in the electronic medical record somewhere? So my nursing staff then devised a dot phrase that we just included into everybody's well visit that got put into their electronic medical record as an ancillary sort of note attached to their physical exam. And then we sort of looked at, okay, well, this is hard. This is not hard, but it's added work for somebody to like fill out the piece of paper and then the nurse to collect the information and then to upload it to the chart or to, revise it. So then we looked at, okay, what are the other things that we can do? And eventually the goal was to put it in the electronic medical record. So like where the patients could answer the questions themselves or the provider if they asked them directly. And those are sort of long-term goals, but the very short-term things, we did those small tests of change on a weekly basis. So, for like 2 or 3 weeks, we looked at, asking my patients to get this information, filling out a form. And then, my nurse providers would say, hey, this question is not good. We got to revise that question. And then we expanded it to a couple of days a week, not just the Monday afternoons. And then the next step was like, okay, I have 4 other providers in my office. There's 3 medical physicians, and then we have a nurse practitioner. Can we, implement it with them? And so we did those for a couple of weeks. And so gradually over time built this process to gather information. And the data that was collected was the paper-based survey that was from the patients. And the feedback from the patients. And so we did this, iteratively over, several weeks. And it took us probably about 5 or 6 months of like looking at data monthly. So we would do things a week, but we would do things on a weekly basis, but kind of look at things and collectively over at a month time frame and deciding, okay, what's the next thing that we can do? So each probably month we did a new step to things, but would change things similarly on a weekly basis. And so it probably took us about 6 months to sort of complete this project or do all of these changes before we came and settled down. Actually, we ended up using only 3 questions. We started out with a lot more, but whittled it down to 3 questions based on patient feedback, based on family feedback, and based on, my clinical staff recognizing that these questions, these are the questions that the kids are answering reliably and have the most sort of utility in getting information from them about their positive outcomes. So we tested these things, and then we would sort of collect data in the form of papers and then as things got involved in terms of the medical record.
Wow, great. Oh, there's so much, you shared so much that your experience is just wonderful. And we can all learn from it. I love the fact that, you really point out that it wasn't just one and done. You didn't just do the same thing for 6 months and then evaluate it. But, just emphasizes the importance of that iterative process. You did it for a day, you did it for a week, you did it, you learned, you stopped, you evaluated, you learned from it, you made changes, whether it was the form, whether it was changing how many questions. It sounds like you got some great feedback from staff about how it worked for them as part of the workflow, and from the patients about which questions they liked or how many questions worked for them. And just shows that, as part of that QI process to be able to move up the ramp. And it took you time before you got to the point that you were going to implement that change. And
we learned very quickly that one of the questions was not useful at all. So like we stopped asking that question after, 1 or 2 weeks because it really, the kids didn't understand the question or they were answering like with very long sentences. I was like, okay, we don't have time for this. So it's important to look at is like, we can change things pretty quickly. We can take something out really quick, or we can add something, very quickly. It doesn't have to, wait months or weeks before we do that.
Exactly. And I know, Aimee, you participated in this initiative in a different cohort than Deborah did. And so I wondered if you could share, based on, she was a faculty member by the time, your cohort participated, how you took, or what you took from what you heard her experience was, and how you tested that in your practice.
Yeah. So one of the great things about participating in quality improvement projects is the collaboration that you have amongst like all of the people that were in this group. So there were pediatricians, adolescent medicine specialists from, around the country that were participating. So I was able to use sort of the hard work that Deborah put in with all of the questions that she had already sort of asked. And she was able to share that with the group through an interactive like app that we had called Padlet. And so I was able to get her survey from there and look at the questions she was asking, and then also, look at the information that's in the, the positive like screening recommendations from the American Academy of Pediatrics. Because I agree, we tend to be very negative in these questions with adolescents. Like, what are you doing that's negative to your body? What are you doing that's negative? And then counseling on them. And I felt like focusing the initiation of your visit on strengths also is a way to gain the trust and of your patient, and also the respect of the parents. It allows them to see that you're seeing them as a person and engaging with them. And so they also are able to be more open. So what I was able to do from what Deborah's questionnaire said was just immediately just had a dot phrase that I would just, because our EMR system, you can create these like shortcuts. And so I created just a shortcut. So whenever I was in the room and I had an adolescent visit, that would populate in my adolescent note. Or actually, I used it for any child pretty much 6 years of age and older that would talk to me about like, what makes you feel happy? What do you like to do for fun? What's one special thing you like to do with your best friend? Just different questions that I would start the conversations with. And then I sort of had like a shortcut phrase where I would remember to ask, those 3 like pertinent questions that I sort of gained from Deborah's, from her questionnaire. And that way it was very consistent across the board with like what I was asking those children. But then for the test of change and the quality improvement project, I just looked at ages 8 and older, not younger than 8, although I did use it pretty much across the board with any child that was willing to be interactive.
Thanks. I really appreciate the fact that you took what you learned from Deborah and you used your technology that you had access to be being able to use the dot phrases, add the dot phrases, was kind of another step that maybe some of the other teams, based on their technology, were able to do as well. Deborah, I know you started on paper, but because the way you did it, I know you didn't like create like huge numbers of, 500 copies of that 6 question. You started small, so maybe you had 10 copies and you got the results. So, so often that's kind of the test of change too. It's about those rapid cycles. I love that then you didn't put everybody at risk. You don't go on forever. But you really learn from it. So, Aimee, you took it to the next step. I wonder, both of you now, in terms of implementing what you've done, how have you scaled it up? Is this something that's now happening at your practice? And I know, Aimee, you said how are you taking this to the larger organization to be able to share it with colleagues at other locations?
My goal would be, once I get, because we didn't just study strengths we also had other minor tests of change, like brief interventions and safety plans for suicidal ideation. So my goal would be after I get more organized and put everything together, I can help work with our electronic medical records department and come up with these like dot phrases or shortcuts that would work for everyone, so that, and then they can just like as a organization send it out as like an update to the system, so that other people can just incorporate that into their well visit note or into their if they have a note about an adolescent who's suicidal, they can just, it's just a way that's easy for them, like a shortcut to incorporate it in.
I'll say that, what you're saying is like trying to translate it to other organizations or, larger in the department. We started out with paper and that, how it worked. And eventually my goal was to put it in our electronic medical record. That took several weeks or months because I have to, think about the system as well. But eventually we were able to put it into our, it's not even a dot phrase. It's like embedded in our entire note, where it's just part of the heads history, which is now our shades history, looking at the strengths and starting that out. And so it's, took several months to get that part, but that, it's now embedded in there, as well as the next step for us. And so this project is ongoing for us, is that we have now developed a patient forward questionnaire that the patients will fill out in advance of the visit, that providers can look at, that includes a lot of their medical history, but also includes some of these other things that are in there. And so now the patients can answer the questions in advance. And so now I'm developing that not only for our division, but also for the larger Department of Pediatrics. And we're testing it with just 18 to 21-year-olds. So not even just adolescents. We're starting out with a very small cohort of kids that are 18 to 21 years of age, so young adults. And using this patient forward questionnaire, this is a very small part of that patient questionnaire, but using those, putting those strengths in there as well, so that the providers can know in advance, hey, these are the wonderful things about this patient that you can use and develop that relationship and rapport, like you're saying, that Aimee was saying from the beginning. It helps like set the tone and set the conversation, and helps you recognize that establishing a relationship with your patient and not always just focusing on the negative, the risk behaviors. We want to focus on the wonderful, positive things that all of our patients have that bring to that patient encounter and bring to their overall mental health.
You make some points that are so important for sustainability. I love how you've incorporated it into now the adolescent well visit, testing it with a small cohort, but that's sustainable. So often when we do these projects, I worry that when the project ends that people are going to say, okay, that's over. We don't have to do that anymore. But both of you have really thought and reflected on how to make this sustain, not just at the practice level, but also to be able to think about how this fits into adolescent well care routinely, so that it really will be part of the way you do business, and this workflow. Great idea too, to be able to think about it as part of pre-visit work, so that you have that information. Another idea of that starts as an idea that then can be tested and become something long term. So thank you both for sharing what you have done and what you're planning to do. I'd love your thoughts too about, the importance of this work. How do you think that the impact of doing quality improvement work where you're testing change and making these type of small changes that have a large impact, in this case on mental health as part of the adolescent well care. Could you share a little bit about your thoughts about the importance of sharing this work with others and other places it may be helpful to be able to share besides, this opportunity we have today is really terrific. We hope a lot of people will gain access to it.
So, the importance of sharing this work, besides the obvious reason, is that we are having such a large increase in mental health illnesses in the last 5 years or so, especially amongst younger and younger children, I think is just to sort of show other pediatricians and family medicine doctors and adolescent doctors that you can do some of this work in a short amount of time and not take away the compassion and the quality of care you're given, but also improve your ability to efficiently document. But then also our goal is to provide transformational care, to provide a small change that will lead to a larger outcome in our children. And so I think part of me looking at this as like, in a busy pediatric practice where, 20 patients a day would be a light load. So to have to like incorporate something that mental health, you feel like you might be opening up a can of worms, and that could lead down a long pathway that's going to lead you to be in the room for a really long time with the patient, and you just don't have that kind of time. And that's sort of the way the medical field has been going. But that's not why we went into becoming a doctor or a advanced practitioner. And so we have this like ethical struggle that we're dealing with, and quality improvement projects like this are helpful for me to find a way that I can still provide that compassionate care and that direct focus on what is causing distress for that family and that patient and that child at the moment, but yet not let it consume me that I'm taking away from the care that I can give to other children. Because I do have to see those other 19 children in that day. I can't spend my whole day on the one child. So it's a way to kind of for me to realize like I can do these small things that will overall improve the care that I'm providing to patients. And I think the more people see that, the less maybe like reluctance we will have to keep adding and adding and adding things we're supposed to be doing onto our visits every day.
Yeah, no, it makes perfect sense. Thanks for those thoughtful reflections. Deborah, how about you? What do you see as the importance of this work?
I mean, I think, we're as primary care providers trying to provide the best quality care to our patients and families in a short period of time. As Aimee said, we have a short visit with patients, and this is not only important for patients, but it's important for other providers and at other institutions or within our institution. Because if we can make some change, then we can make it broader and expand it to others and allow other individuals and other providers to see the benefits to it as well, and recognize that, hey, these little small things can make a big difference for patients and families. Not only like for our patients and safety and the quality that we give to our patients, but if you're a provider in an academic institution, you're kind of expected to have some scholarly activities outside of just necessarily delivering patient care. And this can be a really great professional development area, as well as like niche for providers who are a little afraid of research, like it's a daunting to do a research project or to get funding for it, or how to, thinking about the time frames that are involved in that. But quality improvement can actually be a great scholarly activity that you can promote to others, and you can get national, international recognition for it, just by doing small things in your office that are meant to help your patients overall. There's ways of publishing it. There's ways of communicating it. Obviously, this podcast is a great way of communicating these ideas and these strategies. And so I feel like we start with our patients. That's where it's coming from. That's where the goal and the driven is. But there's other areas and avenues that this work can promote and further that can be helpful for you as an individual, as a provider in professional career.
I just wanted to kind of circle back to the fact that just to share with everybody that, we heard one example in particular about, incorporating strengths into adolescent visits, but I know that there was a lot of work done on improving brief interventions, and there was Aimee, I just, before we leave, I want to circle back to what you mentioned that you worked on with the safety plan, because that had to do with a different aspect of the visit. And, when you're screening, you've identified a patient who's at risk for suicidal ideology. I just, before we end, could you share a little bit about that test of change? I know it's kind of circling back, but I'd appreciate if you would do that.
We do see a lot of youth with suicidal ideations, not always an actual plan or a history of self-harm, but a lot of youth are reporting they're having these urges and these thoughts. And we sort of felt uneasy, like they tell us this information and then we send them home because they're not at risk for an actual plan or follow through. But we came up with like a very simple documentation that we actually do have on paper, because we print it out and send it home with the child so they can put it like on their refrigerator in their bedroom, wherever, take a picture of it on their phone. And we just found out a couple simple questions that we wanted them to ask. And this actually incorporates back into the strengths, because we sort of discuss with them, are there any precursors to you feeling this way? And once you have those feelings, like it might be sweating, it might be overactive thoughts, like whatever the child is telling us. And we write down those feelings so the child can then know at that moment, oh yeah, these are those feelings I'm having that might lead me to have these urges of self-harm. And then the next part on the paper is, well, what are your strengths? What can you do to overcome these urges? Because you are strong enough to overcome them. And that might be, like drawing a picture, taking a walk, calling my best friend, anything that the child identifies, doing push-ups, as something that is a strength to them that they can do at that moment to sort of, I always like to say, to like redirect your brain or to sort of coach your brain in a different direction. And then the next step on the page is just a list of numbers. Like, if this doesn't help, who are you going to call? And who's the trusted adult that you're going to call? Is it a teacher, a friend's mom? Is it a grandparent? Is it your parent? And just putting that on there. And then also we just had a list of the national crisis lines as well as our local crisis lines. And they just have it all there. And that is something they could even share with their school, with their, if they went to a summer camp, if it's almost like an asthma action plan that they can have. So that way, in that moment when they're not able to constructively think necessarily on how to overcome that urge, they have a plan in place so that they can just follow those steps and hopefully make them feel better. And the feedback we got from the patients, they ended up leaving, like they were very tearful when they started talking to us about their feelings. And then they ended up leaving our office with smiles on their faces because they felt supported and that it wasn't, I guess they felt like their feelings were heard and that they were supported. And of course, after that visit, we again helped reach out for them to get external mental health services and other things as well. But this was like, do we send you home tonight or do you go to the hospital kind of thing? And if the safety plan worked, then I felt comfortable sending them home rather than having them, have to stay overnight in the hospital for having these thoughts. So it actually turned out to be a really positive experience we had. And, maybe the handful of patients we had with these thoughts over the 6 months did seem to respond well to having the safety plan.
Thanks for sharing that, because it's just another example of a tested change where it was a smaller cohort, but you tested this and you identified that it would be useful, similar to the way you use your asthma action plan. You kind of modeled it, it sounds like, in a similar fashion so that it's accessible, and collected some information and really put this into use. And Deborah, I know that we talked with another practice who created a different resource that then tested a resource that families found useful with the coping cards. Wonder if you could share.
So, as primary care providers, we want to be able to provide some tangible things for patients in the office. Like Aimee said, creating a safety plan with them and writing down the steps. This is what I'm going to do. This is who I'm going to call. This is what happens next. And so, as we're sort of evaluating or waiting to see if patients get into mental health services, what can we do in the primary care setting? And so some colleagues created some coping cards, and they could be used for kids who are experiencing anxiety, or they could be used for if their kids were experiencing just depression as well. And they are very similar to what Aimee was just describing. Is it's very patient forward and very patient focused. Instead of me saying, hey, when you feel anxious or when you start to worry about things, you should do this. It gave the patient some suggestions, like they can, imagine that they're in their happy place. They can go for a walk. They can pet their dog. But it also, there were 4 cards that had some behavioral things to do, activating things that they can do. And then there was a kind of a blank card that the patients would fill in for themselves to say, when I feel this, I'm going to do these 1, 2, 3, 4, or 5 things. And it was very patient forward, patient facing, and them to actually look at the card to say, okay, I need to practice this right now. I'm feeling anxious. I'm feeling overwhelmed. What am I supposed to do next? And instead of them having to rely on remembering what they need to do, they just pull out the card, and the card says, I'm supposed to, go play basketball, or I'm supposed to go throw the ball against the fence, whatever the case may be. And so it was really helpful for this practice to develop these cards, distribute to the patients, and actually, work in the office with the patients. Okay, we're going to fill out this card together, and you're going to put on the 5 things that are going to be helpful for you when you're in a negative place, or we're in your sad place, or you're in your, anxious place. And that will help distract you and help you get moving you forward so we can get out of that sort of, unfortunate situation at that point in time. As we're helping you get attached to or affiliated with mental health services where you can learn more coping skills or more strategies for ongoing mental health improvement. So I think there's lots of different areas for behavioral intervention that can be done in the primary care setting, and we can sort of do these small little tests of change and develop these cards, or develop whatever your next step is to think about how can I improve my patient's mental health, which is their which is ultimately a factor in their physical health as well, and their overall health and in terms of patient family outcomes.
Your examples really show me that, one of my favorite quotes in quality improvement is to share seamlessly and steal shamelessly. So there's no reason to reinvent the wheel, but both of you have shared examples of, things that are ideas that others have tested, that you've tested and used in your own environment as well. So I think that there are a lot of great ideas that you each have shared during this episode for our listeners to take away. Anything else in particular? Do you have a favorite quote that related to quality improvement that you find, that you think about when you're doing this work?
I don't have a favorite quote, but one of the things that I think we highlighted from the very beginning is that this is not this is not an individual sort of thing. This is a very teamwork and collaborative process. You want to get as many people involved as you possibly can, especially those people that are positive and motivated and want to help and want to succeed in terms of patient and quality safety outcomes. So is it your nursing staff? Is it your physician assistant? Is it, your patients? And so I think that's really one of the big things that I want to highlight from this is that, I might be leading the project, but I'm not the only person that is involved. And it is a collaborative process that hopefully achieves, positive outcomes for everyone involved.
Yeah, I agree with Deborah. My past experience with something with research was actual bench work in like a pharmacology lab. So when I think about research, I think about that and think, oh my gosh, how am I ever going to do something like this with my regular job? But these small changes that you can make in utilizing the resources and the people around you is very important, and also makes it that much easier to complete. And so one of the, I don't know if it's a quality improvement quote, but when I was listening to another Conversation Corner podcast, one of the speakers had said something like, we want to be transformational, not transactional. And that really stuck to me, because sometimes I feel like a lot of things we do in our everyday life are just transactions, and we just go through the motions, and there's no thought or compassion behind it. And like, that's what I want to do. And that's what I wanted to do with this quality improvement project, was be transformational, like help improve these lives of children so that they can be productive adults. And I think this quality improvement project helped me see that these are ways that I can do this and not be in a bench, in a lab, because that was the career I didn't choose. I chose to go into clinical medicine. So I felt like this was very like inspiring for me but when I first started it, I was very nervous and not sure if I could even do it. But knowing that I can have the support of the American Academy of Pediatrics, the group that we had, and then also expanding the support from my network that I'm at, and the positive responses I've gotten have been very encouraging. So
Great. I love that it's not transactional. That kind of emphasizes what I was talking about at the beginning, where it's never just one cycle of change. It's not just one and done, but it really is, that you're moving up a ramp until you get to the point where that something's an improvement, and you're going to implement it so that it is a transformation. It's a workflow change. It's policy change. It's, it may be changes to, just the way you do business. So that's, I appreciate that. Deborah, if you could share with our audience, what's one thing that they could do today or tomorrow for their own small test of change based on?
So I think it's, important for us to recognize that mental health is physical health, and we can help patients and families in the moment. And so whether it's identifying one small thing that you might be able to do in your office, like, I'm not a mental health professional. I don't know, how to do cognitive behavioral therapy. I don't know how to do dialectical behavioral. I don't know how to do, therapy per se. But what are the things that I can do that I know that can help calm my patient in the moment? Whether it is like creating a Stanley Brown safety plan, or creating, a card that helps them sort of calm themselves down. So I think it's, just thinking about what are some behavioral interventions that you can do in your office. Is it teaching patients like a breathing exercises, square breathing, or doing patient imagery. So picking one simple thing and trying it out with your patients. Don't expect to try it out with everybody, but try it out with one or two of your patients in families in the moment, and see how it goes. And maybe you can sort of learn how to do it a little bit better by soliciting feedback from the patients and families, and then trying it out again with somebody else. Again, like pick one thing that you want to sort of focus on and help with your patients, and try like little small things to see if you can get some successful outcomes.
Thanks. And Aimee, if your one comment you want to share?
I agree with that. And I actually, I did find it sort of fun to do those things, like trying something new that I had never done before, like a small intervention in the room, and then like getting that immediate like positive experience from your patient to you. That's really rewarding too. So trying out these small little things we can do, and then seeing that impact that you make as the patient leaves the room is so rewarding that it makes you want to do it again. And so I feel like this quality improvement project showed that doing those small things is really helpful for everyone, not just the clinician, but then also for the parent and their family and the patient. So just give it a try and see what works for you.
Great messages from both of you. It's really been a great opportunity to have this conversation today with both of you. So thank you for joining me and sharing, shedding light on this topic of testing change. I think that your real life experiences were really meaningful and others will be able to just try it with the next patient that you see. So thanks again and take good care.